Welcome to the other side of Lucy Letby. In episode 82, we're going to finish off with these two clowns that we were talking about last week. That's Liz and Caroline, who made this childish podcast telling the world what happened during Lucy Letby's trial. And all they did was simply parrot the nonsense that the prosecution stated. Now, they did repeat often, as we'll hear, because we're going to listen to a little sample of it. I know that's really difficult, but it's good fun too. They did say that Lucy Letby maintained her innocence and denied all the charges. But there's absolutely no inquiry in this journalism at all, which is very strange to me because one of the podcasters is actually a lecturer in journalism at a college in Salford. But we know that there are some concerns, and we don't know what the outcome of all of this will be, that Operation Hummingbird or Cheshire Police may have paid towards the cost of producing these podcasts. Now, the podcasts were produced for the Daily Mail newspaper, but they were produced by a company that was funded by Operation Hummingbird. Operation Hummingbird also paid this company for media relations training, and the payment to the company, called the Media Factory, appears in the accounts of Operation Hummingbird as payments for publicity. So there are two payments for publicity and for training to the Media Factory. The Media Factory made the podcasts, but apparently the Daily Mail owns the podcasts. So you can work out whether you think there's a conflict of interest in journalists taking payments from the police to report on the activities of the police. In any event, last week we looked at Baby C, and we're going to revisit Baby D because it was the second part of this episode 5 podcast of the trial of Lucy Letby. And this time we're going to tear apart the crap that these two people talked. So why don't we just get into listening to it?
Welcome to episode 6, Baby D.
Baby D was a baby girl. She's the only baby in this case who was not born prematurely. She actually weighed a healthy 6 pounds 14 ounces when she was born, and the court has heard that she should never have even been in the neonatal unit at the Countess of Chester Hospital. She was only there because the hospital made a mistake.
Well, the first thing you have to say is that a mistake is a single, isolated incident. Something like maybe the wrong dose of a medication, the misidentification of a patient, or chopping off the wrong limb. So mistakes are categorized by their seriousness. And mercifully, most mistakes in medicine are what we call a slip of the pen. They're relatively inconsequential, spotted pretty quickly, corrected, explained to the patient, and don't do much in the way of harm. Negligence, on the other hand, is a breach of duty of care through recklessness. And recklessness is the conscious disregard for safety or gross incompetence. And gross incompetence is pretty much defined by a persistent failure to follow protocols or established methods of practice aimed at achieving good outcomes. So every couple of years, you have international conferences, you have United States conference, you have European conferences, international conferences, where all of the most driven people in the world get together to decide what is the best way to treat all of these conditions that arise in these babies. And you reach a consensus which is likely the best approach to getting the best outcome. Now, everyone won't be able to maintain that consensus, or they may not be able to maintain that consensus because of resources, circumstances, different things. But as part of that consensus, you will also have a list of things that you do not do. And that is the fundamental goal of any intervention in medicine. Primum non nocere, above all, do no harm. Therefore, no matter what you do, you cannot do certain things because doing those certain things is going to harm the patient. And any action that acts as a risk multiplier for the particular condition that you're treating or the particular patient that you're treating, if you're persistent in carrying out that action, you're grossly negligent. And we will see as we proceed just how grossly incompetent these people were, and just how stupid the journalist is by simply parroting the talking points of the prosecution that this was a mistake. No, they were not mistakes. They were gross negligent breaches of established guidelines. And the failure to establish that from the start is a deception now perpetrated by journalists who are ignorant of the facts but make no effort to inform themselves of the facts, and in that regard are no different than a typical propagandist. And we will see, we will look at each of the multiple breaches very briefly as they occur and as they're reported in this podcast.
Her mother's waters broke more than 2 days before she was delivered, but the hospital didn't give her antibiotics, and baby D was actually born with a suspected infection.
And we can tell you, because we know, because the postmortem told us, that it wasn't a suspected infection. It was an actual infection, and it was pneumonia. And given the condition of the baby at birth, it was probably a congenital pneumonia, a pneumonia that occurred in the womb. And the protocol breach of not giving the antibiotics to the mother when she first showed up has massive implications for mortality risk in the baby. It's not a mistake. It's a catastrophic failing.
Now, this is less than a week after the death of baby C and a fortnight after the death of baby A.
And this is part of what I call the golden thread. And the golden thread is spun into a yarn. The death of baby D had nothing to do with the death of baby A or the death of baby C, except for the commonality of incompetent care.
The jury have been told that baby D's mother had a pretty smooth pregnancy, but the issues began when her waters broke in the middle of the night at 1 day short of 37 weeks. That's the stage of pregnancy that's considered full term.
Except it's not the stage of pregnancy that is considered full term. What is considered full term is 37 weeks, not 36 weeks plus 6 days. That's preterm. So this breaches the National Institute of Clinical Excellence, or NICE guidelines, NG 25, which clearly states that for women with preterm, pre-labour rupture of membranes, or PPROM, that the patient should receive an antibiotic called erythromycin, 250 milligrams 4 times a day, for a maximum of 10 days, or until the woman is in established labour, whichever is sooner. If erythromycin is not tolerated, because it often makes people sick, oral penicillin is used as an alternative. So antibiotic prophylaxis, so that's trying to prevent infection by the use of antibiotics, is specifically recommended for preterm babies such as baby D. At 36 weeks plus 6 days, that is a preterm baby. Now, if the baby was more than 37 weeks, which it was not, then antibiotics are not routinely recommended. And therefore, baby D was misclassified as a near-term baby rather than a preterm baby. despite the fact that the Royal College of Obstetricians and the National Health Service, through the NICE guidelines, uniformly define less than 37 weeks as preterm. But by sending the mother home, they also breached the guidelines for the management of suspected rupture of membranes. These are not mistakes. These are systemic failures. These women require immediate assessment, and that would include a speculum examination, pH testing of any fluids coming from the vagina, and ultrasound to confirm the diagnosis of rupture of membranes. That didn't happen. A systemic failure. And then discharging her back home without confirming the rupture of the membranes violates the NHS guidelines on how to manage these patients. And that will result in a risk increase to the baby of 3 to 5 times for a mortality increase, because this mother didn't get antibiotics for 60 hours. And you have to remember that we don't just add the risks together, we multiply the risks. They are synergistic. In other words, they affect one another. So as we do these risk calculations, they're multiplying each other all of the time.
She rang the hospital and was told to come in later that morning. But when she and her husband went into the Countess maternity unit, her contractions hadn't really started, so she was sent home again.
And I think she went home, Liz, for 24 hours and went back the next day, but again, things had not progressed.
So we're now 36, 48 hours, whatever, into this so far undiagnosed premature rupture of membranes. And we're multiplying the risk by 4.1% for every hour without antibiotics. And no one seems to give a damn. That is not a mistake.
Yeah, so at this point, doctors decided to try and induce her. The mother told staff she was worried about infection, but they reassured her that everything was fine.
Breach of guidelines, breach of guidelines. How do they know that everything is fine when they don't know if the membranes have actually ruptured, and they have not covered the mother in anticipation of them rupturing because the mother is preterm?
And Liz, why was she so concerned about an infection?
So once a mother's waters break, and doctors sometimes refer to this as the membranes going, there is a risk that the baby or the mother can pick up an infection if there's a delay in the baby being born. The court heard that baby D's mother should have been given antibiotics as a matter of course, because that was hospital protocol for a woman who went into labour before 37 weeks, or prematurely, which she technically did by 1 day.
There's nothing technical about it. It's absolute. She was before 37 weeks gestation. Therefore, she had a premature rupture of membranes. Or one had to assume she had a premature rupture of membranes. This is not a mistake. This is a breach of guidelines. And there ain't anything technical about it.
But these weren't given, and the jurors have been told that this was an error on the hospital's part.
Again, it's not an error, it's systemic incompetence.
And it was actually 60 hours after those waters had broken that baby D was born.
Along with the induction of the labour, which was a perfectly reasonable strategy, the mother should have been given a single dose of corticosteroids to reduce the risk of respiratory distress in the newborn. That guideline was breached. That's not a mistake. That is incompetence. She should have had blood tests to detect subclinical infection, which she didn't. That's not an error. That's incompetence.
Doctors initially wanted her to have a natural delivery, but eventually they realised an emergency C-section was needed.
And why did they realise that an emergency C-section was needed? Because they noticed signs of fetal distress in utero, meaning that baby D was compromised, seriously compromised, before she was even born. Not because of mistakes, but because of incompetence.
And I think from the minute she was born, Mum was really quite worried.
Yes, and she gave evidence in court and told the jury that although the doctors said baby D was in a good condition at birth, she just wasn't convinced. She said that when the doctor who delivered her daughter held her above the sheet in the operating theatre for her to see, she appeared not alive. She said she seemed lifeless. She didn't scream. There was no sound and everything was quiet in the room. They brought her to me, but very quickly took her back because they were concerned. It seemed a bit rushed. They took her back pretty quickly.
And yet, the Countess of Chester Hospital, and we don't know who in the Countess of Chester Hospital, because there was no doctor present at this delivery, despite the fact that they knew there was fetal compromise. But whoever took the baby somehow managed to dredge up an APGAR score of 8 out of 10 at 1 minute after birth and 9 at 5 minutes. Now, an APGAR score for the baby that the mother described, grey, lifeless, not crying, is actually 0, which is a medical emergency. But we don't hear of anyone resuscitating baby D at birth. As I say, there was no doctor present. That doesn't mean that a nurse didn't give rescue breaths, but that wasn't stated in court. And if that was the case, the APGAR score will stay at 0 by 1 minute and will stay at 0 by 5 minutes. And an APGAR score of 0 at 1 minute is associated with a 90% increase in mortality for the baby. So this was a major failing of the defence and the defence's medical experts not to investigate this forensically and highlight the systemic failings.
And just 12 minutes after being delivered, the baby actually collapsed and went floppy in her father's arms. She needed a few rescue breaths of oxygen and she did recover. But Liz, her parents were really worried because she wasn't interested in feeding either, was she?
Yeah, that's right. Her mother told the court that the baby was grey and limp and struggling to breathe.
We do therefore have evidence of rescue breaths at 12 minutes, not at 1 minute or 5, but at 12. And we also had the outrageous claim from Sandy Bowen that the father was somehow responsible for this collapse at 12 minutes. An unforgivable statement to Beck.
Lucy Letby was not baby D's designated nurse. In fact, she was being looked after by another nurse called Caroline Oakley. Now, she was very experienced and had 20 years in the job. We've heard that ideally babies in intensive care should have one-to-one nursing, but on this particular night, the unit was very, very busy. Nurse Oakley had baby D in nursery 1, but she also had another baby to look after in nursery 2, which was the room opposite.
And the jury have also heard that Lucy Letby had responsibility for 3 babies, 2 of which were in cots close to baby D in nursery 1 and another child in another nursery nearby.
So now we learn of yet more systemic breaches of NICE guidelines, British Association of Perinatal Medicine guidelines on the allocation of nurses to specific types of babies. Nurse Oakley should not have had a baby in another room. Lucy Letby should not have had 2 babies in room 1 and another baby in another room. But we also know from this statement that Lucy Letby was looking after 2 babies in cots beside baby D. So when Nurse Oakley vanished from the ward for reasons that you can't remember, what was Lucy Letby supposed to do if baby D got sick? Would she have been in a better position if she had ignored baby D when it got sick? Absolutely not. That would have been used against her. But again, these aren't mistakes. These are systemic failings and systemic breaches of agreed consensus guidelines on the amount of nurses you need for each sick baby.
Baby D's mum told the jury that when they got to nursery 1 that evening, Lucy Letby was the only nurse in the room. She described her as hovering around, but not doing much. She had a clipboard to take notes and was sort of looking at the machines, she said. I asked if everything was okay, and she said yes, she's fine. But baby Dee's mother said Lucy Letby was making her feel uncomfortable. She said she could have just left us to it, but she stuck around. She was watching and looking over to us, and I asked my husband, can you tell her to go away or give us some privacy?
So we've just missed an enormous chunk of the case against the hospital for the care of baby D, because the mother was transferred with the baby to another room after the delivery and left there for 4 hours before the baby was admitted into the neonatal unit. And this was despite the fact that the baby had a recorded collapse in the theatre at 12 minutes, was born with an evident AVCAR score of 0, and the mother had to constantly ask for a review of her baby that was failing to feed, that was grunting, that was not making any effort to cry at all for 4 hours. And eventually, someone listened to her and transferred the baby to the neonatal unit. Now, Liz and Caroline's description of what the mother says here is confusing, to say the least, because in the mother's statement, she said that she visited the baby in the neonatal unit the following day at about 7 p.m. Now, Lucy Letby had 2 babies in nursery room 1, as we've just heard, and she would have come on to work at 8 p.m, an hour after the mother got there. And the first thing that Lucy Letby would have had to do is the equipment check, which was the exercise with the clipboard. But the mother is suggesting that Lucy Letby was interfering with them by doing this job, and that her husband should ask her to leave nursery 1 and the other 2 babies then, so that the mother could have some privacy. The mother also said that she was told by a doctor that the baby wasn't great for the previous night, and that the baby had been up and down all night, struggling with feeding, that she had been spoken to by a female consultant doctor that morning, and implies that the consultant told her that the baby wasn't great, and that every time they tried to take the baby off a CPAP machine, the baby would crash. So none of this scans for me, but it doesn't seem to concern Liz and Caroline. But then nothing does it?
Now, I think the defence dispute that this nurse was Lucy Letby because they say she came on duty later than 7 o'clock that night.
Yes, that's right. But when Ben Myers, Lucy Letby's barrister, asked baby Dee's mother about this, she was pretty insistent it was Lucy Letby she had spoken to.
So in this situation, the mother is pretty insistent, even though Lucy Letby wasn't on until 8 o'clock and had to do all those jobs when she got there and couldn't have left nursery room 1, even if she'd wanted to. But the mother's inconsistent when she describes a baby with an AVCAR score of 0.
OK, so the parents spent some time with their daughter, who by then, the jury were told, was doing well. She'd been taken off the ventilator, but she still needed a bit of help with breathing, and that was via a mask over her nose and her mouth, which gently forced oxygen into her lungs. But Dr. Elizabeth Newby, she was a consultant in charge, she said that she was stable. So her parents went back upstairs to rest. And I think baby Dee's father was allowed to stay with his wife in a private room on the maternity ward.
The couple went to rest on the ward, leaving their daughter in nursery 1 in the neonatal unit.
And over the next few hours that night, it's alleged Lucy Letby tried to kill baby Dee 3 times, succeeding on her 3rd attempt. Liz, what did the prosecution say happened in the early hours of June the 22nd?
Well, it was around 1:30 in the morning when baby Dee stopped breathing for the first time. Her designated nurse, Nurse Oakley, had taken a break and had asked another nurse to keep an eye on baby Dee. She hadn't been gone long, though, when she was called back to the unit. The alarms monitoring baby Dee's heart rate and oxygen levels had sounded, And Lucy Letby and another nurse, Catherine Percival Calderbank, had asked Nurse Oakley to return quickly. They'd also called for the registrar on duty, that's a doctor called Dr. Andrew Brunton, to attend to see Baby D urgently. Both the doctor and the two nurses told the court they noticed the baby had an unusual red-brown rash on her body, on her tummy, on her arms and her legs. And Nurse Oakley gave evidence to the jury, saying that she had never seen anything like it before.
So we're back to skin discoloration. And there's a big problem with all this skin discoloration, because we hear these people saying that they'd never seen it before, that they didn't know what it was, etc. But we don't hear at any stage of any attempt to find out what it was. So there was a massive failure to diagnose the reason for the skin discoloration. Now, we've talked endlessly about skin discolorations. They are a reflection of circulatory failure in the babies. So they're a sign of perfusion deficit, in other words, shock. And if you haven't seen a baby with shock before, you shouldn't be looking after babies that may go into shock. And a baby who has pneumonia has been intubated and is not great and struggling with CPAP is definitely a baby who's going to go into shock.
And Liz, listeners might remember this rash is significant because the prosecution say that doctors talked about an unusual rash on the bodies of babies A and B when they were allegedly attacked a fortnight before.
Yes, the prosecution say this rash, which came and went within the space of a few minutes, was caused by air being injected into the bloodstream of the babies.
So there we have it. Within the space of a few minutes, and I've argued countless times, Professor Xu Li said that he attributed the cause of the pink flitting rash that he observed to the direct oxygenation of hemoglobin adjacent to free air in the vasculature. Now, apart from the fact that that's an attribution and not proof, and could just as easily have been a trick of the light, air that enters into a vein and remains in the venous system will never reach the peripheries and will be absorbed into hemoglobin within seconds. And if it does cross over this patent foramen valley into the left side of the heart, it will become an arteriolar embolism and cause immediate collapse and death without ever reaching the skin to cause skin discoloration. And that's the evidence that the jury were never told, and that Liz and Caroline probably wouldn't understand even if we did tell them. You can't have a good story destroyed by very cold, hard facts.
This is what they allege Lucy Letby did when she attacked or killed them.
So, to go back to Baby D, Dr. Brunton, the registrar, and several nurses rushed to her cot and started treatment.
They gave her a few rescue breaths with the Neopuff. That's a type of mask that the jury have heard is put over a baby's nose and mouth to give them oxygen quickly. And fortunately that worked, and she picked up pretty quickly. In fact, her heart rate and her breathing was back to normal, and the rash had disappeared within half an hour.
Within half an hour. So you have a baby with a rash, you give them Neopuff or you give them oxygen, and within half an hour the rash is gone. Therefore, the rash was caused by lack of oxygen, not, as the prosecution say, the presence of oxygen.
But at 3 a.m, just over an hour later, she collapsed again for the second time.
Yes, Dr. Brunton told the court that he remembered he was on the children's ward nearby when his pager went off. Nurses informed him that Baby D was crying, her oxygen levels had dropped and the rash had reappeared. They increased the amount of oxygen being given to her, and by the time Dr. Brunton got to Nursery 1, a few moments later, her breathing and heart rate were back to normal, and she didn't need any extra treatment.
Are we beginning to see a bit of a pattern here? I'm certainly seeing a bit of a pattern. The baby starts crying, gets distressed, goes without oxygen, gets a rash. The rash is representative of underperfusion. They reperfuse the baby and the rash goes away. That's how a normal doctor would look on this situation.
So Liz, just to recap, baby D collapsed twice, at 1:30 and then at 3 a.m. But because she'd recovered, the parents weren't disturbed.
And don't forget, a baby who has just collapsed twice was a stable baby. And as even a layperson knows, stable babies don't collapse once, let alone twice.
Nurse Oakley said staff had planned to tell her parents about the incidents the next morning, but they left them sleeping because the daughter had recovered.
An hour later, that all changed when baby D collapsed again. And another more junior doctor, Dr. Emily Thomas, now she told the court that she remembered Lucy Letby being the nurse who called for help and that she was upset. Dr. Thomas said Lucy Letby said, "This is my second baby that this has happened to."
Yes, and this time baby D didn't respond at all, Caroline. The nurses began CPR and a crash call was put out, and Dr. Brunton came back quickly. He also tried to contact the consultant on call, Dr. Newby. The court heard that Dr. Newby arrived at the hospital just after 4 a.m. to help Dr. Brunton.
So that's a 15-minute delay from the collapse to the arrival of the consultant. That is the total duration of an episode of CPR, during which the most senior doctor was absent.
And along with Lucy Letby and Caroline Oakley, they tried to get baby D's heart to restart. Over the course of the next 28 minutes, they gave her CPR and administered 6 doses of adrenaline, but they just did not get a response.
And at this point, Liz, nurses did go and get her parents to bring them to Nursery 1 because it was clear that their daughter was seriously ill.
To a normal doctor, it was clear long before this terminal event that their daughter was seriously ill.
As we've heard, the parents had gone to rest a few hours earlier, but the next thing they knew, they were woken up in the middle of the night by a nurse in a panic. Baby D's mother explained what happened next to the court, and her words have been voiced here by an actor.
"She just said our daughter was very poorly and you need to come down. We were fast asleep, so we didn't really know what was going on. The nurse helped me get into the wheelchair and we rushed downstairs. Dr. Brunton was holding her, trying to resuscitate. He was trying really hard. We were just standing there looking at her dying. Someone was holding a phone to his ear. He was quite agitated. And then Dr. Newby told him they had to let her go. He had to stop. She tapped him on the shoulder and said, 'You've got to let her go.' He stopped massaging her and pronounced the time of her death, and I couldn't stay in the room anymore, so I asked my husband to take me away."
Now, the jury was also read a statement that baby D's dad had given to police about that night. Again, his words are spoken by an actor.
"When we walked into the room, it was obvious immediately it was a very serious situation. There were lots of medical staff around my daughter. Dr. Brunton seemed to be in charge. I remember someone mentioning adrenaline and a real sense of urgency. They were unsuccessful in resuscitating her. Dr. Newby came to inform us that she had died. She said they had been trying to resuscitate her for 20 minutes. I think Dr. Newby had to tell Dr. Brunton to stop. Dr. Newby seemed shocked and upset. I couldn't tell you which staff were there when she was being resuscitated. I didn't want to look. I was never given the impression my daughter's condition was life-threatening, and it didn't even cross my mind that she was in danger of dying. When she died, we were just not prepared for it."
So why were the parents not told that a baby with pneumonia and sepsis who had required intubation and still required mechanical ventilation, even though that was reduced unadvisedly, wasn't seriously ill? How more seriously ill can you get than to be almost term, to go 60 hours without antibiotics that were mandatory, without steroids that were mandatory, and to end up with exactly the situation that you're trying to avoid by giving those antibiotics, pneumonia and sepsis, both of which are notorious killers of babies, that their baby wasn't seriously ill. And I think it's because the Countess of Chester Hospital didn't know that the baby was seriously ill.
And Liz, baby D was pronounced dead just before 4:30 in the morning on June the 22nd. And the prosecution case is that Lucy Letby caused her death by injecting air into her bloodstream. The jury have been told that she was the common denominator, that she was the one nurse on duty on nights over the previous fortnight, when the prosecution say baby A and baby C died and baby B was attacked. And like on previous occasions, soon after she finished work on June the 22nd, after the death of baby D, Lucy Letby began WhatsApping her colleagues.
So why were the parents not told that a baby with pneumonia and sepsis who had required intubation and still required mechanical ventilation, even though that was reduced unadvisedly, wasn't seriously ill? How more seriously ill can you get than to be almost term, to go 60 hours without antibiotics that were mandatory, without steroids that were mandatory, and to end up with exactly the situation that you're trying to avoid by giving those antibiotics, pneumonia and sepsis, both of which are notorious killers of babies, that their baby wasn't seriously ill. And I think it's because the Countess of Chester Hospital didn't know that the baby was seriously ill. And then we get a long discussion about Lucy Letby's WhatsApp messages as if they mean a goddamn thing. And then Liz and Caroline discuss the review into baby D's death.
And I think what Lucy Letby said to her friend there in the messages and what the doctors had predicted was right, wasn't it, Liz? There was an investigation by the hospital into whether anything had gone wrong before baby D's death.
Yes, a review was carried out into the care given to baby D's mother, and tests were taken of the placenta and her blood. Baby D's body was also sent to Alder Hey Hospital, the specialist children's hospital in Liverpool, for a post-mortem. It revealed that baby D did have an infection, but it wasn't sepsis. In fact, she'd been born with pneumonia. The review also found that the hospital should have given baby D's mother antibiotics when she was in labour. Despite this, though, Joanne Williams, the doctor who carried out the review, said neither the placenta or baby D's mother showed any sign of infection in the hours after birth, and she doubted whether a dose of antibiotics would have made a difference.
But the Thirlwell inquiry does provide us with a little bit more insight into the disastrous decisions made during the care of baby D. But because the right questions weren't asked at the Thirlwell inquiry, we don't get a complete answer. So let's look at what Dr. Newby's statement said about baby D, and not Joanne Williams, who was a nurse. So this is part of a statement by someone called Jane Tompkinson, and she was appointed as acting chief executive officer of the Countess of Chester Hospital Trust in December 2022. And in section 7 of her statement, it goes, secondly, the Trust received a complaint by the parents of baby D regarding baby D's care whilst at the neonatal unit at the Trust. The complaint can be located within the parents' witness statement, signed 27th of January 2016, and I will attach as Exhibit JT35, and forms part of the overall proceedings brought by baby D's parents against the Trust. Within this witness statement, baby D's parents state that they believe baby D may have been taken off CPAP, a form of ventilation for breathing support, too early, with notes showing that every time she was taken off the machine, she crashed. The statement further records baby D's parents disputing the APGAR score given to child D or baby D at her birth. Baby D, as we've said, was given an APGAR score of 8 at 1 minute of life and a score of 9 at 5 minutes of life. Within their witness statement, baby D's parents disagreed with the score given, stating baby D seemed limp, of dusky colour and lifeless, or as I've said, an APGAR score of 0, 0, nada. Baby D's parents also raised concerns in their statement over the actions of staff in the immediate aftermath of Baby D's collapse, claiming to hear someone on the phone saying, "Baby D, no, it's Baby D," while massaging her. They continue to state that it's not clear who he was talking to or why he was doing that. The family also queried why the mother was not provided with antibiotics before being sent home when her waters had broken. Elizabeth Newby, she was a consultant, discussed some of these concerns with the parents in a meeting and further clarified her views in an email from Elizabeth Newby to Heidi Douglas, sent on the 17th of March 2016, and I attach as Exhibit JT36. So we have this information at the Thirlwell inquiry, but we don't have this information at the trial. On the topic of the potential removal of Baby D from the CPAP machine, Dr. Newby wrote, "In hindsight, it may have been better to leave Baby D on CPAP, but it is extremely doubtful that this would have altered the course of events." So it seems that Liz and Caroline, the media rock stars, have got this all wrong. We're not talking about antibiotics, which would, of course, have made a huge difference. We're talking about CPAP and the baby being taken off CPAP by Dr. Brunton far too soon. When Baby D collapsed, says Dr. Newby, she suddenly stopped breathing and then lost her output. CPAP offers some respiratory support to a baby who is breathing for themselves, but it is not ventilation. Therefore, CPAP would not have been enough to prevent the collapse or help during the collapse. It feels, in hindsight, the wrong thing to have taken her off CPAP, but we couldn't predict at the time that she would suddenly collapse, and therefore, when she was in error, with a normal set of observations, the registrar on call felt it was reasonable to try her off, knowing that it takes seconds to restart it if coming off and it is not tolerated. Now, it'll come as no surprise that I completely disagree with Dr. Newby, and I see again the same illogical pattern of thinking or pattern of illogical thinking in these consultants. CPAP should be weaned gradually when infants meet stability criteria. Well, Baby D just had a collapse, as they referred to it, so hadn't met any stability criteria. And one of those typical criteria would be maintaining CPAP at 5 centimetres of water, that's just the pressure measurement, in less than 30% oxygen for 12 to 24 hours. And the sudden removal of CPAP without meeting any of these criteria risks respiratory fatigue, hypoxia, and most importantly, acidosis. That would be respiratory acidosis and metabolic acidosis. And that is the build-up of lactic acid in the blood because the baby isn't getting enough oxygen. And remember, we have no measurements of blood gases during this whole process of Baby D's collapses because no one seems to have bothered to take the measurements. But acidosis, as we have said here many times before, profoundly affects cardiac muscle contractility, the ability of the muscle to work and pump out blood. And it will blunt the effect of adrenaline to kickstart the heart. So the pathophysiological or causal chain that Dr. Newby doesn't seem to appreciate the possibility of is respiratory fatigue leading to hypoxia, leading to lactic acidosis, leading to refractory cardiac arrest. So it's perfectly reasonable to say that in Baby D's case, unmonitored acidosis could easily explain the sudden collapse itself and the failure to respond to resuscitation. So the premature and abrupt weaning of a very ill baby like Baby D from any respiratory support probably caused metabolic acidosis, in my opinion, and we'll never know because they didn't monitor it. So we have another link in the chain of incompetent treatment. Now, I've said this multiple times before. I don't blame the third year and fourth year registrars that are doing this stuff. It takes a long time to get this all into your head and working automatically and smoothly. And then in paragraph 10 of this Thirlwell document, finally, regarding concerns over incorrect APGAR scores being given to BBD, Dr. Newby wrote, a paediatrician was not at the delivery. And again, this is a major breach of NICE guidelines that clearly state neonatal staff must attend deliveries for fetal distress and emergency sections with non-reassuring fetal status. Yet another systemic failure. Not a mistake, a systemic failure and a clear protocol breach. And the consequences of there being no paediatrician there is delayed resuscitation. And the consequences of delayed resuscitation are poor outcomes, including hypoxia of the brain, cerebral palsy, and death. But of course, there was no one at the Thirlwell inquiry to ask Dr. Newby about that, and that would have been, anyway, more relevant to the Lucy Letby trial than the Thirlwell inquiry. So neonatal resuscitation and mortality go hand in hand, and mortality is 2 or 3 times higher when resuscitation is delayed or if it's inadequate. And Dr. Newby goes on in her statement in paragraph 10 that a midwife documented the APGAR scores and the fact that no resuscitation was needed at birth. The paediatric notes record 5 and 10 minute APGAR scores, but I also found a 1 minute APGAR score in mum's obstetric notes. This issue of baby details being recorded in mum's notes has been discussed, highlighted as a risk and the action taken. But it's very clear to me that if a midwife recorded an APGAR score at 1 minute in the mum's notes, then there was no paediatrician there at 1 minute. And if the APGAR scores were 0 at birth, they would have been 0 at 1 minute without resuscitation. So the APGAR scores, which were used to prove that baby D was well when baby D was born, are, in my opinion, misleading evidence. But that's not the type of thing that Liz and Caroline are interested in. They want to talk about WhatsApp messages, post-it notes, and Gary Evans fantasies. So we can see that the trial, the award-winning podcast by Liz and Caroline that Cheshire Police may have funded or helped fund as part of their publicity funding, is yet another misleading crock of shit by 2 ham broadcasters who know nothing about the subject on which they're speaking. And I don't know for the life of me how it won an award, what award it won, what competition it was up against, and why anyone would ever want to listen to it. But the failings were systemic and breached protocol, guideline after protocol guideline throughout the baby's care. A normal pregnancy that became a high-risk pregnancy when there was a premature rupture of membranes that went untreated with antibiotics for 60 hours. An emergency cesarean section that was not attended by a neonatologist. The mother left begging for help for 4 hours before the baby was finally admitted into a neonatal unit. A junior doctor admitted the baby into a neonatal unit and made the decision to intubate, which was reversed very quickly, without any evidence of a senior doctor reviewing either decision to intubate and the decision to extubate. No monitoring, systemic monitoring that I can find for blood gases, an X-ray that showed transient tachypnea of the newborn, which was obviously the pneumonia and which only occurs in less than 1% of near-term babies anyway. And as for Liz and Caroline's erroneous assumption that nobody found sepsis and pneumonia can coexist. And if you have pneumonia sufficient to kill you, as was the case for baby D, you're going to have sepsis because there's so much blood flowing through the lungs. It's not going to be able to avoid picking up bacteria. But we have to come back to the same problem again. Why were these people admitted into a unit that had at least 2 very serious pathogens floating around unchecked? And I see a pattern here. Baby A, baby C, baby D, baby I, baby O, baby P, they all ended up in this place. The ones that stayed the longest, baby D being one of them, ended up with pneumonia. Unless you do PCR testing or advanced biological testing at postmortems, which is not the norm or the standard, you're not going to know what bug actually caused the infection. And postmortems don't always find that. And in fact, if you use cultures or normal methods to try and find bugs at postmortem, you're going to find loads of them. And it makes it very difficult to isolate which one is actually the pathogen. So all of this evidence is evidence of systemic failure without a shred of evidence of Lucy Letby harming any baby. So that's me done with Liz and Caroline. I have had to endure listening to their childish podcast for the sake of doing this podcast and to really highlight, I hope, to people just how bloody useless it is and why you shouldn't waste your time listening to it. So we'll leave it there. I hope you got something from that, and we'll keep on going. We'll keep on knocking the door until people start listening and answer the door. The systemic failure in this unit was epic, and that's why the babies died. Nothing to do with Lucy Letby. So we'll leave it there, and we'll see you in the next episode. Bye.